Hello everybody. Today we are going to talk about hematuria. What is hematuria? Hematuria or blood in urine. We have two types of hematuria. Gross hematuria that is visible to naked eye, or we have microscopic hematuria that is detectable only on examination of the urine sediment by microscopia. And we can say if we see more than 3 RBC in high power field. A way to quick test urine, we have a dipstick test. What is dipstick test? A thin plastic stick with strips of chemical on it is placed in the urine to detect abnormalities. The chemical strip change color if the certain substance are present or if their levels are above normal. And we can see the dipstick test in this picture. And dipstick test can be negative or positive. Negative can be false negative. False negative is unusual, but ingestion of large amount of vitamin C can cause false negative dipstick test for hematuria. True negative dipstick test. And what is true negative dipstick? We can say that there is no problem, but some foods and some drugs can change the urine color. For example, beet, rifampicin, sulfasalazine, ibuprofen, blackberry, metronidazole, and salicylate. And we can see, and we think that this is gross hematuria, but it's false. False positive. There is no hematuria, absence of hematuria microscopic, but it's very important. Because of some setting can induce the false positive. For example, hemoglobinuria, intravascular hemolysis, myoglobinuria, rhabdomyolysis, presence of semen in men, pH above than 9, deferoxamine because it's a chelator for iron, and also iron sorbitol, menses in women, formalin fixation, and dilute urine because of osmotic lysis of RBC. And we can in this setting we cannot see the RBC in high power field, but we have true dipstick. And we have a true positive dipstick for hematuria. And the main goal of this video is true positive hematuria and evaluation of it. And we can say that we have to follow an algorithm to understand and to distinguish the cause and sources of the hematuria and bleeding. And we have to ask the first question: is acute onset unilateral flank pain present? If it is no, if it is yes, it means that we have to evaluate nephrolithiasis, and if it is no, we have to ask the second question: if there is UTI symptoms, white PC, positive nitrate. If it is yes, we have to ask for urine culture and treatment if needed. And if it is no, we have to ask for presence of clot indicates, and we have to ask for presence of clot, because presence of clot indicates for lower urinary tract source or some internal causes, infrarenal causes, I'm sorry, for example, kidney cancer. And we have to ask for abdominopelvic CT, sonography, and cystoscopy. Also, urine collected during menses or after acute trauma or vigorous exercise is very important, and we have to repeat UA after 6 weeks in the absence of the menses. And if it is negative, we call it transit hematuria, and if it is positive, we call it persistent hematuria. And I have to say that use of antiplatelet or anticoagulation drugs cannot influence this algorithm. And for distinguish the location and the source of the bleeding, we have to notice some important clues. The first of all, we have to say that presence of RBC or dysmorphic RBC or proteinuria, especially albuminuria, seen in the glomerular disease. And blood clot almost always due to non-glomerular bleeding because of two important causes: presence of orokinase and TPA, and also we have minute amount of blood in the glomerular disease, and also presence of acanthocyte comprising more than 5% of RBC has 98% specificity for glomerular disease, and also one of the most important clue is the time of onset. Also, new onset hypertension and edema, and urine acidosis may result in formation of methemoglobin, that is brown or cola. Hesitancy and dribbling are seen in the BPH, or some cancer of the bladder. Why hesitancy and dribbling are seen in BPH? Because and it causes the hematuria, because new vessels in the BPH are fragile, and it causes the hematuria. Family history of polycystic kidney disease and hereditary nephritis is very important, and also recent upper respiratory infection raises the possibility of post-infectious nephritis or IgA nephropathy. And we have an idiom here that is idiopathic hematuria. I can say that there is no proteinuria, no infection, no radiologic findings. But hypercalciuria and hyperuricosuriia can induce the idiopathic hematuria. And also we have some rare conditions such as Nutcracker Syndrome, AVM or arteriovenous malformation, schistosomiasis, and low in pain hematuria. But what is Nutcracker Syndrome? Compression of renal vein between superior mesenteric artery and aorta, and also perineal varices raise the possibility of this syndrome. And we can see in this picture the Nutcracker syndrome and the compression of renal vein between superior mesenteric artery and aorta. Thank you.